Ma, please go
Bismillahirrahmanirrahim.
ahead.
Bismillahirrahmanirrahim. Thought of the day is silence is the language of God, all else is poor translation. Assalamu alaikum. My name is Dr. Inshrah and I'm a PGR of Community Medicine and Public Health at King Edward Medical University, Lahore. So the topic of my presentation is measles and I'll be presenting it under kind supervision of Professor Dr. Saira. Our learning outlines will be introduction to measles, epidemiological determinants, clinical features, phases, complications, diagnosis, prevention, control measures, global data, recent advances, and then MCQs. At the end of this presentation, the participants will be able to define measles and understand its etiology, define the key epidemiological determinants of measles transmission, recognize the clinical presentation of measles and identify how the disease progresses through different phases, describe the preventive strategies and discuss the control measures for measles outbreak, review global measles statistics. Introduction to measles. Measles is a highly contagious viral disease caused by measles virus, part of the Paramyxoviridae family. It spreads through respiratory droplets and can lead to severe complications like pneumonia and encephalitis. Despite the availability of effective vaccines, outbreaks persist globally due to gaps in vaccination coverage caused by misinformation and healthcare barriers. Epidemiological history. Measles was first clinically described in the 9th century, showcasing its long recognized impact on human health. The development of the first measles vaccine in 1963 by John Anders and colleagues marked a turning point in controlling the disease globally. In Pakistan, the vaccine was introduced into the extended program of immunization in 1978 to reduce its burden. Dynamics of disease transmission. Reservoir. Humans are the only known reservoir for the disease for the measles virus. Mode of transmission. Measles spreads through the respiratory droplets either via air or direct contact. Incubation period is 4 to 17 days, during which the virus multiplies in the body without visible symptoms. Period of infectivity. Individuals are infectious from 4 days before the rash appears to 4 days after. Epidemiological determinants include agent factors, host factors, and environmental factors. We'll see all these factors one by one. First of all, agent factors. The causative agent of measles is the measles virus, a member of the paramyxovirus family, which is highly contagious and responsible for the disease widespread transmission. Host factors among these is the age and immunization state. Young children, particularly those under 5 years old, are more vulnerable to measles as their immune system may not be fully developed or protected. Immunization status, individuals who are not vaccinated or have not completed their vaccination schedule are at high risk for contracting measles. Environmental factors. First of all, there is living conditions. Among these is overcrowded living environments, poor sanitation, and inadequate nutrition. And then healthcare access. Limited access to healthcare services and immunization programs, especially in rural or underdeveloped areas, increases the likelihood of the outbreak. Moving forward to the clinical features, a person suffering with measles can present with fever, cough, coryza, that is runny nose, conjunctivitis, red watery eyes, malaise and fatigue, rash, and Koptic spots. Phases of measles, the 4 phases: incubation period, then prodromal phase, rash phase, that is also known as exanthum, and finally recovery or complication phase. Incubation period. The duration is 7 to 14 days after exposure to the virus. During this period, there are no symptoms present. This phase is asymptomatic, meaning that there are no visible signs or symptoms. The individual is not yet contagious, but the virus is multiplying in the body. It is important to note that while the person may not be ill, they are incubating the virus. Then prodromal phase. The duration of this phase is 2 to 4 days before the rash appears. Symptoms include high fever, often peaking at 40 degrees Celsius or 104 degrees Fahrenheit, respiratory symptoms like cough, coryza, sore throat, and conjunctivitis, that is reddening of the eye. Koplik spots, small white spots with a red base typically appearing on the inside of the cheeks, oral mucosa. This phase is critical for diagnosing measles. The presence of coplic spots is a key diagnostic feature, along with the combination of respiratory symptoms and fever. The rash does not yet appear, making this phase tricky to distinguish from other viral infections. Here is the picture attached where you can see these small white spots. These are the coplic spots. Then moving forward to the rash phase, its duration is 3 to 4 days. A maculopapular rash appears starting behind the ear and on the face. The rash spreads downwards to the neck, trunk, and limbs in a cephalocaudal direction. The rash may become raised and red, eventually darkening before fading. This is a small boy. You can see here the rash is only on his face. The trunk has no rash. And then in this picture, the face, neck, trunk, and even extremities are involved. Recovery or complication phase. The duration of this phase is 2 weeks after the symptoms subside, but complications may arise. That is another situation. The recovery phase is marked by the subsiding of the rash and fever. However, if complications like pneumonia or encephalitis develop, further medical intervention is necessary. Recognition of these complications is crucial for proper treatment. Now, complications of measles. There might be some early complications or delayed complications. Among early complications, we have otitis media, pneumonia, diarrhea. In delayed or late complications of measles, we have encephalitis, persistent immunosuppression, and subacute sclerosing panencephalitis. Here in this slide, I have compared the rash of measles with some similar diseases. You can see we'll move in this direction from measles and rubella, scarlet fever, and then varicella. In measles, there are red spots. These are maculopapular rash. First of all, they appear behind the ear, face, and then trunk and extremities. One characteristic feature of this rash is the red spots joined together. You can see here, the spots are joined together, 3 or 4 spots. And this is non-itchy rash. In rubella, the red spots appear first on the face and then to neck, trunk, and extremities. But the difference in the rash of measles and rubella is this: the spots are not joined together. You can clearly or distinctly see this rash. The spots are far away from each other. Again, this is a non-itchy rash. In the scarlet fever, the red spots that are in the form of papules appear first in the neck or chest, especially involving the armpits. You can see reddening here in the armpits of this boy. And then the rash spreads to the body. Face is flushed, but there is some pale area, especially around the mouth. This is called circumolar pallor. And obviously there is strawberry tongue. In chicken spots, red spots appear that then turn into vesicles. You can see this base is red and then vesicles. These are fluid-filled blisters. This is intensely itchy. One difference is that in the varicella or chickenpox, the rash appears mostly on the trunk and scalp and less on the hands and feet. And one other thing, in chickenpox, the rash appears in crops. Means some rash appears and when it is in the settling phase, another rash appears. Moving forward, measles and pregnancy. There are risks to the mother and there are risks to the fetus. Pregnant women, particularly in the first trimester, are at increased risk of severe complications, including pneumonia, encephalitis, and other respiratory issues. Measles can lead to prolonged fever, which may worsen mental health and increase the likelihood of hospitalization. A risk to the fetus include miscarriage, preterm birth, or low birth weight. Congenital measles, although rare, can occur and cause serious birth defects such as developmental delays or neurological damage. Prevention involves vaccination prior to the pregnancy. That is the best way to prevent measles. Pregnant women who are exposed to measles should undergo post-exposure prophylaxis with immunoglobulin. Management involves close monitoring, and supportive care to manage symptoms and reduce the risk of complications for both the mother and the fetus. Measles and HIV. Increased risk in HIV positive individuals, especially with weakened immunity. The challenges when a person who is HIV, who has HIV positive, gets measles is that this is atypical presentation, and there is reduced vaccine efficacy and obviously persistent viral shedding. Management. HIV positive individuals with measles need close monitoring and may require additional treatment or immune support to manage complications. Measles and malnutrition. There is bidirectional relationship between measles and malnutrition. Malnutrition weakens the immune response, increasing the severity of measles, and then measles exacerbates malnutrition by causing diarrhea, anorexia, and increased nutritional demand. Vitamin A deficiency typically presents with measles. This leads to catamalacia and blindness in severe cases. This is associated with high mortality from measles complications. Diagnostic tests for measles involve clinical features that are the fever, maculopapular rash, and Koplik spots, and then some laboratory tests, serology, detection of IgM antibodies that appear 3 days post-rash, and then PCR that detects viral RNA from throat swabs or blood. Vaccination for measles. This is administered as a part of the MMR, measles, mumps, rubella combination. This is a live attenuated vaccine. There are 2 doses. First dose of 0.5 ml at 9 months of age is subcut injection on left deltoid. And then again, second dose of 0.5 ml at 15 months of age, subcut injection on the left deltoid as a part of the EPI schedule. This is the EPI schedule. You can see this 5th and 6th visit on 9th month and 15 months involves the MMR vaccine. Efficacy. 93% after 1 dose, 97% after 2 doses ensures strong protection against measles. Immunoglobulin. Measles-specific immunoglobulin is used for post-exposure prophylaxis in infants under 6 months, pregnant women, and high-risk groups. Should be administered between 3 to 4 days, but the maximum of 6 days of exposure to the measles virus for maximum effectiveness. This should be followed by live measles vaccine in 8 to 12 days. The dosage of immunoglobulin is 0.25 ml per kilogram of the body weight. Role of vitamin A in measles management. WHO recommends routine vitamin A supplementation for children with measles. The dosage is 50,000 international units for children less than 6 months, 100,000 international units for 6 to 12 months, and then 200,000 international units for greater than 12 months. This enhances epithelial integrity, boosts immune response, and reduces severity of complications. Studies show a 50% reduction in mortality among children receiving vitamin A during measles. Primary prevention for measles involves vaccination. That is the most effective method. Ensuring all individuals receive the MMR vaccine on schedule helps prevent measles spread. And then public awareness. Educating communities about vaccination and measles risk increases coverage and reduces outbreak. Secondary prevention involves early detection of the fever, rash, Koplik spots that helps prevent transmission and ensures better management and isolation. Isolation and quarantine of the affected individuals during the infectious period, that is 4 days before and 4 days after the rash, to prevent spread, especially in healthcare settings. And then post-exposure prophylaxis that involves administration of measles-specific immunoglobulin within 6 days of exposure to high-risk individuals that reduces severity and prevents complications. Tertiary prevention involves management of the complications by IV fluids for dehydration from diarrhea or respiratory distress, antibiotics for secondary bacterial infections like pneumonia, and vitamin A that reduces complication and enhances immune functions. Rehabilitation, support for individuals with long-term effects, example given hearing loss or neurological damage to improve quality of life, and then obviously follow-up care, ongoing monitoring of severe complications to manage secondary infections and long-term health issues. Outbreak control measures involve case identification, rapid diagnosis of suspected measles cases through clinical and laboratory testing, prompt isolation of confirmed cases to prevent further transmission. contact tracing, identifying individuals who have been in close contact with an infected person, and offering vaccination to those who are unvaccinated or at high risk. Mass immunization campaigns, conducting vaccination campaigns targeting unvaccinated population, particularly in areas with low vaccine coverage to quickly halt the spread of the outbreak. And enhanced surveillance and reporting, strengthening surveillance systems to detect new cases early with clear reporting mechanisms to ensure timely intervention and resource allocation for outbreak control. Global burden of measles. Annual cases in 2023 were over 9 million worldwide. Deaths were 1,28,000, mostly among the unvaccinated individuals. Sub-Saharan Africa and Southeast Asia experienced the highest burden. WHO estimates that measles vaccination has prevented over 20 million deaths since 2000. Measles-associated mortality. High-risk groups involve children under 5 years, pregnant women, and immunocompromised individuals. Leading causes of death includes pneumonia, 50% of the death, diarrhea in malnourished children, and encephalitis, high mortality or permanent neurological damage in survival. Milestone towards global measles elimination. In 2000, WHO launched the Global Measles Strategic Plan to eliminate measles in multiple regions. In 2010, introduction of the Measles Rubella Initiative to strengthen vaccine campaigns globally. 2019, measles deaths reduced by 73% compared to 2000. In 2021, global measles vaccine coverage estimated at 81%, far below the 95% needed for herd immunity. Current goals of WHO is to eliminate measles in all regions. Challenges for measles elimination involve: first, vaccination hesitancy and misinformation. Second, limited healthcare access in remote areas. Third, weak immunization infrastructure and cold chain issues. Fourth, political instability and conflict zones. WHO's Measles and Rubella Initiative. The World Health Organization has set a target for global elimination of measles and rubella by 2030 as a part of the Measles and Rubella Initiative. This initiative aims to reduce measles death by 95% and eliminate rubella in all regions. The strategies involve vaccination that strengthens the immune programs globally to ensure every child receives the measles rubella vaccine. Surveillance, improving disease surveillance systems to detect and respond to outbreak quickly. And outbreak response, strengthening outbreak response efforts in high-risk areas to contain the spread of the virus. America's measles elimination. In 2016, the Americas became the first region to declare measles eliminated. These strategies were high vaccination coverage, robust surveillance, mass immunization campaigns. Lessons learned were: this success highlights the importance of strong immunization systems, political commitment, and public health infrastructure. Measles elimination efforts in Pakistan. There are many national campaigns. Then obviously there is WHO collaboration. In 2013-14 outbreak, the outbreak highlighted gaps in coverage, prompting vaccine emergency campaigns and heightened public awareness. While MCV coverage reached 84% in 2023, over a million children remained unvaccinated. Natural disasters and ongoing vaccine hesitancy complicate further elimination efforts. Conclusions and future direction. Strengthen routine immunization that focuses on improving vaccination coverage in underserved areas, ensuring both doses are administered on time to control measles. Overcome vaccine hesitancy. Public education campaigns and community engagements are essential to combat misconceptions and encourage vaccination. Ensure equitable healthcare access. Improve healthcare access in remote and marginalized communities to reach children and prevent outbreaks. Collaboration for elimination. Coordinated effort from government, international organizations, and local communities are essential for strengthening vaccination programs and ensuring global measles elimination. Moving forward to the recent updates. Measles cases upsurged worldwide, infecting 10.3 million people in 2023. Worldwide, there was an estimated 10.3 million cases of measles in 2023, a 20% increase from 2022, according to the new estimates by WHO and CDC. As a result of global gaps in vaccination coverage, 57 countries experienced large or disruptive measles outbreak in 2023, affecting all regions except the Americas, and representing a nearly 60% increase from 36 countries in the previous year. The WHO African, Eastern Mediterranean, European, Southeast Asia, and Western Pacific regions experience a substantial surge in cases. Nearly half of all these large or disruptive outbreaks occurred in the African region. Surveillance of measles virus seropositivity amongst vaccinated children of the rural areas of Central. Serum samples were collected from 173 children using standard sample collection protocol. Measles-specific IgG antibodies were quantified using enzyme-linked immunosorbent assay. The study recruited children with an average age of 41.3 months, evenly split between 88 males and 81 females, all vaccinated as per their parents' record. The measles IgG antibodies seropositivity ratio in children among the vaccinated population was 30.6%, and among the seronegative individuals was 69.4%. The study revealed alarming rates of measles susceptibility among vaccinated children in Pakistan. These findings emphasize the need for improved vaccination strategies to address deficiencies in immunity levels and mitigate the risk of measles outbreak in the region. Measles seroprevalence in adolescents and young adults living with HIV in response to MMR booster in seronegative ones. The objective of this study was to analyze people with HIV, measles, seroprevalence in response to MMR booster given to seronegative individuals. This was a cohort study with 4 groups: vertically infected individuals, horizontally infected individuals, and 2 control groups. An MMR booster was offered to seronegative individuals. Results showed that measles seropositivity and IgG antibodies were significantly lower in vertically affected HIV individuals than in other groups. All measles seronegative patients responded to booster. The conclusion was an MMR booster must be sought during adolescence in vertically transmitted people with HIV. Measles and Rubella Strategic Framework 2021 to 2030 in collaboration with Measles and Rubella Initiative, American Red Cross, CDC, UNICEF, United Nations Foundation, and WHO. The vision is a world free of measles and rubella. The goal is to achieve and sustain global measles and rubella elimination goals. Strategic priorities include 7 priorities. First of all, primary healthcare and universal health coverage, then commitment and demand, coverage and equity, life course and integration, outbreaks and emergencies, supply and sustainability, and research and innovation. The core principles of this plan are people-focused, country-owned, partnership-based, and data-enabled. Moving forward to the MCQs. A refugee camp with overcrowded living conditions reports a surge in measles cases. Investigations reveal that infected individuals are spreading the virus through coughing and sneezing, with cases occurring even in distant parts of the camp. What mode of transmission is primarily responsible for this outbreak? A. Fecal oral transmission. B. Direct contact with the infected skin lesions. C. Airborne spread of respiratory droplets. D. Vector-borne transmission via mosquitoes. Or E. Contaminated water supply.
C.
Yes, the correct answer is child. An unvaccinated 8-month-old baby is brought to the hospital with fever, cough, and a maculopapular rash. The mother reports that older siblings recently had measles. Which host factor most likely contribute to the baby's susceptibility to infection? A. Poor hygiene practices in the household. B. The baby's young age and lack of vaccination. C. Overcrowding in the home. D. Nutritional deficiencies in the family. E. Exposure to multiple environmental triggers. The correct answer is beta. A 6-year-old child presents with high fever, cough, runny nose, and red watery eyes. The mother reports these symptoms started 2 days ago, but no rash is visible yet. On examination, small white spots with a red base are seen inside the cheek. What is the significance of these spots? A. They confirm the child has a bacterial infection. B. They indicate the child is in the incubation phase. C. They suggest the child is immune to measles. D. They are characteristic of the prodromal phase of measles. Or E. They are the sign of scarlet fever.
D.
The correct answer is delta. A 4-year-old unvaccinated boy develops a high fever and respiratory symptoms. 3 days later, he has a maculopapular rash spreading from his face to his limbs. His parents ask how long the rash will last. What is the typical duration of the rash phase in measles? A. 3 to 4 days. B. 4 to 6 days. C. 5 to 7 days. D. 6 to 8 days, or E. more than 10 days? The correct answer is alpha.
C,
Years after recovering from measles, a teenager began showing progressive neurological symptoms, including seizures, behavioral changes, and loss of motor skills. MRI findings indicate inflammation in the brain. What delayed complication should be suspected? A. Meningitis. B. Guillain-Barré syndrome. C. Stroke. D. Viral encephalitis. Or E. Subacute sclerosing panencephalitis.
D.
Yes, the correct answer is eta. A pregnant woman in her first trimester has close contact with someone diagnosed with measles. She is not immune as she was never vaccinated. What is the best preventive measure for her to avoid contracting the disease? A. Immediate administration of the measles vaccine. B. Administration of measles immunoglobulin within 72 hours of exposure. C. No preventive measure is required. D. Starting antiviral therapy immediately. Or E. Post-exposure prophylaxis with antibiotics.
B.
B,
B.
The correct answer is beta. A child with measles is admitted to the hospital with a high fever and pneumonia. The child's nutrition is poor and they have a known deficiency in vitamin A. What benefit does vitamin A supplementation provide in this case? A. It will shorten the duration of the rash. B. It will completely prevent the development of complications. C. It will prevent secondary bacterial infection from occurring. D. It will cure the measles infection immediately. E. It will reduce the severity of pneumonia and support immune function.
E,
Yes, the correct answer is eta. A 4-year-old child with a history of measles and subsequent complications such as hearing loss is referred for long-term care. The healthcare provider advises on auditory rehabilitation and regular follow-up visits. Which type of prevention is being applied in this case? A. Primordial. B. Primary. C. Secondary. D. Tertiary. Or E. Quaternary.
delta,
Yes, the correct answer is delta. A country is struggling to eliminate measles despite strong efforts, with periodic outbreaks occurring in urban slums. Investigations show that many residents have not been vaccinated due to the lack of trust in the healthcare system. What challenge does this scenario highlight in achieving measles elimination? A. Misinformation about measles and vaccines. B. Inadequate supply of vaccines. C. Inadequate funding for vaccination programs. D. Lack of infrastructure for cold chain management. Or E. Ineffective national vaccination policies.
A,
Charlie.
The correct answer is
E.
alpha. Alpha. In 2016, the World Health Organization declared that measles transmission has been eliminated in the Americas. What was a key factor in achieving this milestone? A. Introduction of a universal vaccine for all infectious diseases. B. Limited international travel to and from the region. C. Widespread measles vaccination and successful immunization campaigns. D. Strict travel bans on individuals from countries with acute outbreaks. E. Complete eradication of the measles virus from wildlife.
C.
C, Charlie,
Yes, the correct answer is Charlie. This is the key to all MCQs. This is the link of our YouTube channel. And thank you for your attention.
Thank you very much. Very nice presentation, Dr. Inshrah. Would you please stop the recording so that I can give you the feedback?
Yes, ma'am.
Right.